Okay, great. We're going to go ahead and get started on this next session, which will discuss the current evidence around the use of minimal residual disease as a surrogate endpoint in chronic lymphocytic leukemia, as well as the challenges that must be addressed to establish MRD surrogacy. So a lot of the same questions for this panel, but directed towards the chronic lymphocytic leukemia disease area. We will begin our session with a presentation by Dr. John Bird, the D. Warren Brown Chair of Leukemia Research from The Ohio State University. After Dr. Bird's remarks, we'll have we'll have a panel of 5 members who will share their perspectives and insights. Following the discussion, we'll begin with open things up for Q&A discussion as well, right before we head out for lunch. As before, I'll introduce our panel following the opening presentation, but for now, let me just turn things over to John.
I want to thank the organizers for asking me to talk about something that I'm not an expert in, but am very attuned to in the field of CLL. So my disclosures for bias are shown here, noting at the bottom that I am a college football fan, but I also have several patents related to ibrutinib, although they will none of the proceeds will come to me. Yes. So as a background to CLL, there are 15,000 cases diagnosed per year, and just as Ola said in multiple myeloma, we're blessed over the past several years with new drugs approved by the agency that the prevalence of CLL goes up by the year because patients are living much longer with this disease. Patients often present with asymptomatic disease. We treat the disease, at least right now, when patients become symptomatic, based upon older studies showing no advantage to early treatment. The fingerprint of CLL offers many ways to follow the progress of the disease and sort of gives a pathway to knowing how we can follow minimal residual disease. Because if a mutation or something changes over time, it's not going to be very useful for following minimal residual disease. And in this regard, similar to multiple myeloma, the immunophenotype in the B-cell gene rearrangement doesn't change. One can be followed by flow cytometry, the other by next-generation sequencing, and so these are ideal. You can also get down to a very low level. Where cytogenetic abnormalities, you have modest migration. So you can pick up abnormalities over time, you can select out abnormalities, and it's not as sensitive. And then finally, driver mutations the CLL is born with. Maybe good surrogate endpoints that we can use for minimal residual disease in the future, although we don't know that right now and there's no prospective data. So let's talk about the evolution of CLL. And as with multiple myeloma, when I started in this field, there was no such thing as MRD negative CLL. There was no such thing as a CR. And fludarabine brought that to light, where 20% of patients went into complete response, a morphologic complete response, where when you looked with sensitive methods, everybody had evidence of disease. We were just fooling ourselves that the disease wasn't there. Fludarabine cyclophosphamide, so chemotherapy, the same thing. And it was really the first impactful therapy that changed survival of CLL, rituximab, which it added to chemotherapy, that shifted us into the era where not only did we get a complete response rate, but we had patients living much longer, and we could see MRD negativity using highly sensitive techniques in the 40 to 50% range, where we could say, well, this is something we can do. Quambicil obinutuzumab was introduced as another form of chemoimmunotherapy with a better CD20 antibody, and again, higher CR rate, and MRD occurring again. And we were on our path to MRD as myeloma, and then we had a sort of a wrench thrown into the formula that a great drug came along targeting B-cell receptor signaling, BTK, ibrutinib, which say, induces CR rates the old way in 10 to 20% of patients, but it's incredibly rare. I've treated 700 patients with ibrutinib. I've seen 4 MRD negative patients, say, and yet patients have a 5-year disease-free survival of 92%, better than everything before, that we've had. So the big question relative to MRD and why we're here, for CLL, I think all of us are here. We want to impact patients' lives. We want them to live either, say, their normal lives without symptoms of their disease, say, but with their disease, or to cure their disease. And I would say there are a couple of ways that this can be done. There's continuous therapy, and as say, and the field is really grappling with this. Do we do continuous therapy? Do we do intermittent therapy? And I haven't read that intermittent therapy is going to be most relevant to MRD, because with continuous therapy right now, as I said, 5 years of follow-up with ibrutinib, we're not seeing relapses, we're not seeing evidence of molecular resistance in anybody, and there's very modest morbidity with this, so most patients can be on this therapy. Although it's a costly therapy, and there's the issue of, are the young patients going to relapse with extended follow-up? Are we going to change the natural history of the disease? So, but we're going to focus on, for MRD, intermittent therapy is relevant, and this is relevant for younger patients, and particularly if we want to get patients off therapy, say, for hopefully curing their disease, or for financial or morbidity reasons. So, and this sort of gets to the problem that we have with drug development. Even though we have these, in CLL, we have this disease that remains incurable. Patients have to stay on therapy. And early surrogate markers allow us to acknowledge the new success of a therapy and, and to move on. And CR has sort of been used for this. And we went from a morphologic CR, the NCI 1996, to MRD, to MRD using clone-specific PCR or multicolor flow cytometry to next-generation studies. And the state-of-the-art in terms of these are either flow cytometry or the clone-seq platform, which have different sensitivities. It's flow cytometry with 4 or 6 antigen sensitivity, which can be done. It's reproducible across multiple labs, gets down to the 10 to the -5th. Whereas if we're sequencing the CDR3 region, we can get down to 10 to the -6. That requires central lab, and is, say, and it has not been it has not been validated prospectively. I'm not going to review and sort of bring you up to the field the 30+ year history of looking at this, all the retrospective data, and the validation data of flow cytometry to the CDR3 sequencing. That does exist. Although there's, again, with the new technology of next-generation sequencing, there's not been a single prospective study where the study said, we're going to look at this and see if this response goes with a surrogate endpoint. So we don't have a prospective study, and until we have that, we have all the biases that everybody has talked to before. So what data do we have from the field? Say, unlike multiple myeloma, we don't have a big meta-analysis, but we have large phase 3 studies, and I'm going to show a couple of them. They've not been combined except for a recent analysis that came out 2 weeks ago that I'll show. But the first analysis is from the CLL8, the most impactful study in CLL that showed that we could prolong survival of FC versus FCR. It showed improved survival, progression-free survival, and complete response. And this led to the FDA approval of FCR in fit CLL patients. Prospectively with this, it was a study done by the German CLL group that looked at MRD using the validated 4-color flow cytometry method that's exportable to laboratories around the world with essentially 1 hour of training and good technical skills, and that's done around the world. And they looked at MRD, and going across on the panel. Going across on the panel, you see that we attain MRD negativity over time. And the point that I would make is that the MRD negativity is less in bone marrow than in blood. So we're sort of left with the paradigm we'd like to get away from doing bone marrows in CLL as well, but I think bone marrow probably is still better. And probably the best time to do this is at the end of therapy. And this shows that using a very sensitive, getting down to the 10 to the -4, that at the end of therapy, that in the blood, in the bone marrow is probably a little bit better, and that this segregates patients with modest, no, or positive MRD outcome very significantly. In the multivariate analysis that looks at a lot of other things, I'll call attention to for progression-free survival. For all MRD is significant at all levels, and it has a hazard ratio that's very significant. If you go from essentially probably having morphologic detectable disease to MRD negativity, but when you're getting down to modest to no MRD, the hazard ratio is only 2.81. And when you translate across to overall survival for that subset, you see that the hazard ratio becomes non-significant, probably reflective that CLL may be potentially like hairy cell in a subset of patients, that patients can live a subset can live an extended time with a small amount of MRD. And we saw this from CLGB 9712, where patients who were MRD negative at the end of therapy were disease-free at 10 years. And I'm not showing this. And so, again, a caveat of CLL that's different from myeloma. A second study from Genentech and Roche did, looking at obinutuzumab with chlorambucil, sort of showed the same thing, improved response, progression-free survival, and it led to, again, chemoimmunotherapy in the unfit CLL. And here they showed that in the bone marrow and the blood, you saw higher MRD and MRD negativity, again, at the end of therapy, correlated with improved outcome. The problem with both of these studies, and many of the studies, is they did not harmonize with the new response that includes CT scans, which sort of throws a caveat in why the meta-analysis that Dr. Sargent talked about, where you can look at all the data together to see what's important and what your endpoint is going to be. And so how do we come up with these partial response MRD negative patients that were included in both of these analyses? It comes from a very complicated response criteria that, as I say, I will take no credit in being part of, because it causes challenges for all of us as we look at this, where not only bone marrow is assessed, but also lymph nodes and spleen. And to be a MRD negative CR, you have to have shrinkage of your spleen and your lymph nodes to a normal level. And how this is defined is very nebulous, and so most patients end up being MRD negative PRs. And so the German CLL study, and this is the only composite study that I'm aware of, where they combine data from this CLL8 study they showed, and then a new study that compared FCR to BR, and integrated the MRD negativity data, and essentially showed that for the different compartments, that if you were MRD negative CR or PR, you did the same, particularly if it was in the spleen. But if you had lymph node disease that was positive, your MRD negativity was not as important as in terms of outcome. And again, the same thing translated into progression-free survival and overall survival in a multivariate analysis. So, as we move forward in thinking about MRD, where should MRD come from? Again, looking at the literature, it's very clear that the bone marrow is better. When should we collect it? It should be 2 months post-therapy, at the end of therapy. Which technology is better? Probably the next generation method is better in terms of being more sensitive, but we don't have prospective studies. Flow cytometry is less sensitive, but can be done every place with short training and has been used prospectively. And CT is probably at the single time that you're evaluating response does add something, because if patients have residual lymph nodes, the biomarker means less. As we move forward, caveats that I would say is we have to remember why we're doing these studies. The early we're looking for an early surrogate of progression-free survival and overall survival, and that our new therapies that lack MRD negative status are producing this endpoint. And so if our combined therapies are producing toxicity in the long run, that has to be considered, and that's why incorporating all of the data with our new and old therapies are important to making decisions. All of our prospective published data have been with chemoimmunotherapy, making uncertain that if we throw out chemotherapy, which the field, at least a subset of the field, is going to, whether this will hold true. And really getting patients to MRD negativity, and I believe this sometimes with FCR, which has a 5% chance of causing treatment-related MDS and AML, can impact people 5 or 10 years later. And so we have to consider that just because we make people progression-free, we may not leave them in a good state later on. Thank you very much.
Okay, great. Thanks, John. So now I'd like to introduce the panel. Kicking us off with some comments would be Angela DeClaro, the clinical team leader, Division of Hematology Products at FDA. Following Angelo is Rod Humrickhouse, Group Leader, Oncology Development at AbbVie. Sumitra Mandrakar is Professor of Biostatistics and Oncology at the Mayo Clinic. Carol Preston is CLL Patient Advocate at Patient Power. And then finally, Aaron Logan is Assistant Professor of Clinical Medicine at UCSF. Angelo?
Good morning. First, I'd like to provide some clarification of what FDA, some of the authorities and regulatory background. So I think we've heard some uncertainties today discussed about that MRDs being a shorter-term endpoint. What are the potential risks? To address these, FDA does have authority to require longer-term studies for both efficacy and safety. On the efficacy side, we have the accelerated approval regulations that will allow us to require confirmatory trials for efficacy to provide us data. On the safety side, we have regulations that allow the FDA to require for longer-term safety studies. These are under the FADA regulations, and these are routinely employed in multiple approvals, and these would be conducted as post-marketing requirements. So I just want to reassure the group that acceptance of a shorter-term or intermediate endpoint does not really negate FDA's authority to requiring longer-term efficacy and safety trials, because we find value those in providing that information will be valuable for patients and prescribers. In the field of CLL, where we have multiple approved therapies, a challenge of integrating MRDs, since you have all these multiple approved therapies, the question arises, how does this compare with your other approved therapies? Personally, I think it is of value that to a patient or a prescriber, that if you're deciding on therapies to give to your patient, it will be important to understand, well, how does this compare with the other therapies that are available? Because one makes a benefit risk decision in regards to what therapy would be most appropriate for your patient. Some limitations with MRD is if it's not found in all the other trials, it would be difficult to make that comparison. Hence, the approach that FDA has taken, that I think it's fine to integrate it together with your more traditional endpoints. So together with your traditional endpoints on progression-free survival and overall response rate. So we've actually allowed descriptions of MRD in product labels. But how this will be best integrated in your overall assessment of how to treat patients, I think remains a challenge. Thank you.
Okay, thanks, Angelo. Rod?
Thank you. First, I'd like to thank John for a nice distillation of a very complex area, and thank the organizers for bringing us all together, because I think, again, it takes all of the stakeholders to really solve what is a very complex problem. I think we have a situation in CLL with new targeted therapies where the treatment of CLL has already drastically changed. And I think that we're on the verge of significant more change that can be, I guess, realized. But I think it is going to take some significant advancements in the endpoints that we use, and in particularly MRD or other molecular endpoints, to get us there quickly. I've been lucky enough to be a part of a development program where MRD was identified early, and we've engaged stakeholders throughout the world and across all the different parties, academia, regulatory, and even engaged with different patients. And I think we've identified some I guess difference in understanding, different in expectations, and certainly some significant data gaps, as I think have been identified through discussions earlier today. But I would just like maybe focus on a couple of items that well, my partners that I work with at Genentech on the development of venetoclax, we've identified as we've engaged with parties around the world. Really, one is what compartment for CLL, what compartment should we focus on? I think I might offer an alternative to Dr. Bird's position on bone marrow, because the predictive value, or at least the prognostic value of MRD that has really been established primarily with data from blood assessment. And I think just from a practicality purpose or utility purpose, blood is much more friendly. We can do serial assessments. You could do them monthly if you chose to do so. Bone marrow is obviously much more difficult and much more difficult for the patient. I think it also allows us to address potentially missing data in a way that would be much more difficult with bone marrow. I think in the future we may even look at the rate in which one achieves MRD negativity, or as a measure that would predict potentially for eventual cure, or the time at which one might want to stop therapy. So I think we really as a group need to focus and make efforts to make blood the compartment. We may have to bridge to bone marrow, and that work may need to be done. I think that should be a goal. Second, I would certainly like to speak to the idea of broadening the patient pool in which we assess MRD and count MRD beyond the CRs. Because I think, as mentioned by Dr. Bird, there are patients who clearly have benefit who do not meet CR, and we've been able to establish as well that there are patients who are partial responders by the limitations of our current, even by CT scan, who can achieve MRD negativity in bone marrow when assessed. But the practice is that patients who aren't in CR don't get bone marrow biopsies. So I think both of these components are critical for us to really advance the field, that we come to, I guess, take a consistent approach across both of those two.
Okay, thanks, Rod. Sumitra?
Good afternoon, I guess. So thank you for inviting me to this panel. I think that the next few minutes that I'd like to, from a statistical standpoint, I'd like to lay out the data that we have and probably the next steps that we can take if we truly want to assess if MRD is a good surrogate in CLL. So as Dr. Bird's presentation nicely illustrated, that we do have efficient treatments, so we need long follow-up. So for the standard clinical endpoints of PFS and OS, so yeah, we do need an alternative endpoint. And all of the data that he presented clearly show that MRD is a good prognostic factor in CLL. Going back to what Dan said this morning, that there is good individual level benefit. And then in addition, he also showed data where it said, MRD is an independent prognostic factor, independent of, remission, CR or PR. So I think, so this is very good. There's probably not enough data on surrogacy itself. So I do want to mention, John, there was an analysis presented in ASH this year that actually did some surrogacy analysis based on the same 3 trials that you presented. So they did do the meta-regression or the meta-analytic approach that Dan presented this morning. These were 3 phase 3 randomized trials, and John already presented the data on those. They all are very positive for PFS. And so they looked at MRD ratio, so the negative rate in the treatment versus the control arm, or the end of treatment in all these trials. They pooled all the data together from these 3 trials. And they did, I don't want to go back to Dan's talk too much, but really that's what they did. They had only 3 trials, and so they did what you mentioned about, since you don't have enough trials, they considered, centers or regions or countries as units. But so you can see that the surrogacy effect, or the R-squared value that Dan was presenting this morning, was only 0.56 from this analysis. And clearly that is probably because, again, small number of trials, and these trials were not heterogeneous. They all were very strongly, had a good treatment benefit. So I think that's still things that need to be done in terms of establishing surrogacy. That's probably a good first step. There's probably some evidence that MRD is probably a good surrogate endpoint in CLL, but I think the issue remains. If you want to consider MRD as an endpoint, here are what I think, at least from my standpoint. First of all, we do need multiple randomized trials. We probably need trials that are positive and negative to bring the heterogeneity of the results. The question about how to use MRD, do we pick MRD at a predetermined time point? I guess then the question becomes, what is that time point? How do we determine that? Is it end of treatment? But what happens if treatment is given until progression? I go back to Rod's point of, can we truly, maybe use blood, MRD status assessed in blood, then we can do something like time to MRD negative status. So you can periodically assess and then maybe use that as a surrogate endpoint. So I guess I just want to reiterate that it definitely has value. It's a good prognostic factor, but it still needs a lot more validation before it can be used as a true surrogate endpoint. Thanks.
Great, Sumitra. Thanks for bringing up those points. Carol?
Well, good afternoon, everyone, and thank you so much for including a patient advocate in this discussion. I must say I was very sorry to hear Dr. Bird still primarily advocating for those bone marrow biopsies. Having been on the receiving end of more than a few, I'm really going to vote for Rod's support of using blood somewhere down the line. This hat, if you all can see it, represents a CLL past, or at least my CLL past, having been diagnosed a little bit more than 10 years ago and undergoing a very grueling, I felt, toxic treatment, an older one, CVP plus R, because of a very enlarged spleen, diagnosed at stage 4 on the Rye scale. Having lost more hair than I care to recall, the hat became my favorite tool to appear in public. And my goodness, how far we've come in the past 10 years. Having said that, however, patients are impatient. They are demanding in many cases more effective, less toxic, longer lasting treatments. And certainly with the advent of ibrutinib, venetoclax, acalabrutinib coming down the line, that is happening today, but still there is no cure. It is every cancer patient's dream for a cure to live a normal life. And I have to say, with the exception of being thrown into the hospital after the first attempt to treat me with this older treatment, I have lived a very normal life. I've been able to watch our 2 sons grow up and be launched, basically off the payroll, every mother's dream, and coming up on 38 years of marriage. So a lot of wonderful things have happened. But the question to be asked is, with the FDA support and the advance of 21st century technology, can it happen more quickly? Can it happen more safely? I'm not on any treatment now, and for that I'm very grateful, I'm very blessed. But I might be one day, and will my fate be a treatment of, continuous, an ibrutinib or a venetoclax where I can't get off the treatment? Or will there be something through MRD, for example, if it becomes a viable surrogate or therapeutic endpoint, something else to help me live and maintain quality of life? Because that's what we want as patients. Quick show of hands, how many of you in the audience are clinicians and you treat patients? You know how smart patients have become. This is not your father's patient, much smarter than I am, that's for sure. Not only asking questions, but doing research, crowdsourcing in some cases, becoming very involved in moonshots, not just the vice president's moonshot, but at MD Anderson, for example, the CLL moonshot. Patients are not waiting around and twiddling their thumbs, but they do look to you as collaborators as you mentioned, and as a previous panel member mentioned, to move it forward very quickly using 21st century technology. And that brings me to an issue that I've not heard mentioned since I've been in the room this morning, is cost. If I should relapse and go back on treatment, I am scared to death about the economics. And I know that that's not the subject, that's not the primary subject of today's discussion. But given that it takes 10 years or more for a new drug to be developed, and the cost at $1 billion or $2 billion, do we have the technology and do we have different endpoints to shorten that timeline and perhaps help with the costs of drug development and translate that into the costs for patients? So again, I'm a very impatient patient. I know that your patients are impatient, and I'm hoping all of this will lead to effective, less toxic, safe, and long-lasting treatments.
Great, Carol. Thank you so much for reminding us all why we're here, why this is such an important topic to improve the efficiency of drug development, to bring down the costs and the length of these trials with some of these surrogate endpoints. So I really appreciate you bringing that to us. So finally, to round out this panel, I'd like to turn to Aaron.
Sure. So I'd like to thank the organizers for asking me to be here, and John for his nice summary. Also, I'd like to thank Carol, because I think your comments are a great prelude to some of my thoughts about how we use MRD to actually change the therapies that we use to better fit the patient perspective. And I think CLL is really, it exemplifies the tension that arises as we evolve from using intermittent cytotoxic therapies to using targeted therapies, but with exchanging one set of negative attributes for another. With the cytotoxic therapies, you lose your hair. You run the risk of clonal evolution, creating monsters that we can't treat. You run the risk of therapy-related myelodysplasia. But with these continuous therapies, these are pills that presumably you're going to have to take every day for the rest of your life. And I think we've seen, with chronic myelogenous leukemia, every patient diagnosed with CML over the last 15 years has been trapped in the hegemony of TKI therapy without end. But we're now learning that that may not be necessary. There are patients who achieve deep MRD negative responses who can come off of their TKI and remain in a deep remission. And some of those patients, if they were to progress again and be detected at a molecular level by BCR-ABL PCR, can be recaptured by reinstituting the same therapy. Basically, preemptive therapy the same way that we do post-allo transplant for CMV. And I think this is a model that needs to be explored in clinical trials, and it needs to be soon for two reasons. I think there's a lot of things that we can disagree about here, the strength of data for MRD, the strength of data for different methods. We probably can all agree that our healthcare system is not sustainable if the answer to every problem is a pill that costs $12,000 a month and you're supposed to take it every day for the rest of your life. So this is something that we as a field, we as clinicians, we as people who organize clinical trials need to be sensitive to, and we need to be forward thinking. And so far we haven't done that. So this is an opportunity to learn from the experience in CML, which has taught us so very much, and to design clinical trials that use MRD as a window to evolve the way we treat patients, not just evolve the way that we approve drugs. I'm in the boat with Ola and several others to think that the strength of data for MRD to serve already as a surrogate endpoint is already very robust. I think particularly so in CLL. We have multiple randomized phase 3 studies for which there is MRD data showing excellent correlation with progression-free survival and overall survival. That data already exists. I don't think we need to create new trials to believe in that. But what we do need to do is to incorporate MRD into our studies with the idea that MRD at some point needs to become the primary endpoint. MRD negativity needs to be the primary endpoint, meaning that when you achieve MRD negativity, at some point thereafter you will stop therapy. You won't leave the patient on that pill for the rest of their life. You will continue to monitor them. And so I think that's how we need to evolve patient care, because that's what our patients want, and that's what our healthcare system needs, because we can't afford this current model of therapy. So I wanted to speak very briefly about the methods of testing, because I think it's important to pay attention to the details. So it's easy to talk about how flow cytometry is available everywhere. That's actually not true when you're talking about MRD-directed flow cytometry. There's actually a very important study that was published on behalf of the American College of Pathology, surveying about 120 labs around the country, asking to what degree of disease burden can they assess different diseases, including acute lymphoblastic leukemia, CLL, multiple myeloma, and AML. In CLL, fewer than 30% of labs could detect MRD down to 10 to the minus 4. All the rest could only detect to 10 to the minus 2 or 10 to the minus 3. So most of the practitioners in this room work at institutions whose hematopathology labs cannot give you an MRD assessment. You have to send it to Jerry Radich's lab or somebody who has set up a pathway for that to actually occur specifically. It is not immediately available to every clinician. And so we need to be aware of this. Because the methods that we use in our clinical trials need to then interface with the reality of what we do as providers when we're taking care of patients. If I can't get MRD assessment in my institution, I need to be cognizant that I need to send it out to a lab. I need to be cognizant that there are certain days of the week that maybe I can't collect it because it needs to get to that lab fresh and be analyzed fresh. And so I think that we should be aware of that. There are alternatives. I think some of the molecular approaches, be it ASO, PCR, or the next-gen approach, do offer some benefits in terms of flexibility for sample processing and even some of the sensitivity issues that I won't get into for issues of time. But I think these discussions that the FDA has been having for the last several years about MRD are so very important. But a lot of it has been just about, well, how do we get more and more drugs on the market? And that's not really where I think we should be headed. We should be thinking, how do we provide better care for our patients? How do we achieve MRD negative responses that allow patients to get off of therapy and then monitor them and treat them preemptively before they relapse? And I think that's how we move forward.
Great, thanks, Aaron. So I heard a lot of great points that came out on this panel. I think the group seems to be aligned in the sentiment that MRD seems, particularly in CLL, seems to be a really good prognostic marker, but its use as a surrogate endpoint has more mixed data. But I guess I heard alignment in that we need to figure out a way to get where we need to be with MRD as a surrogate endpoint. And some of the sort of main factors that I heard come up, and I'd appreciate your reaction to what your fellow panelists said, but the main issues, at least from what I heard, seem to be the method of measurement, so blood versus bone marrow, some suggestion of maybe looking at time to MRD status as a potential measure that can be done. The method of measurement, so the different testing that's available, that seems to be an issue that came up, as well as the when to measure. So, John, you recommended like 2 months after therapy. Others are suggesting perhaps continuously throughout therapy. But those do seem to be the main push points that I heard. And Carol, your point about from the patient's perspective on blood versus bone marrow is really important. And I think we really do need to figure out how to get there more quickly. The focus is on providing the best care to patients, not necessarily improving or increasing the number of drugs that are on the market, but really getting to how best to treat these patients. So I won't go necessarily down the line, but any volunteers to react to those main points? John?
So I hate bone marrows more than I hate CT scans, and I think we do both of them too often. But I think I can't agree more with Aaron with why we're here, and so why I think the bone marrow needs to be done for MRD if I'm seeing a patient, because it's 10% better at telling me that if I'm going to stop a therapy, that I'm going to be right. And if the patient forgoes that decision and we stop therapy and we're wrong and they relapse quicker, then that's a personal decision. But if I'm making a medical decision, I want it to be close to being right. But I think the second point, is that it's clear that MRD as a prognostic factor is at a point where we can make a decision to stop, to stop therapy. And I say it's very nice that's harmonized with the approach that hopefully the U.S. intergroup is going to be taking in the clinical trials, and the Germans are taking with combined therapy. And outside of approving drugs, I think Aaron's point is very strong and very patient-centered.
Great.
So if I may say something about the source of sampling. So I think in CLL, actually, we do have the opportunity to use peripheral blood over bone marrow. I think the COVAX study that you showed that combined data from CLL8 and CLL10 demonstrated that if you have an MRD negative CR or PR, the predictive value for progression-free survival was not statistically significantly different, even if there was still radiographic splenomegaly, and even if there was flow cytometric disease greater than 10 to the minus 4 in the bone marrow. So I think peripheral blood in those particular studies serves very well as the hallmark predictor. And I think part of why you may favor bone marrow is because you want to make that big decision: are you going to stop the therapy or not? And I think one of the things that we need to evolve from is the mindset that we've used in COG trials of, you have one or a few opportunities to assess MRD and that's it. With new technologies such as molecular testing, we can do serial monitoring of the peripheral blood. And I think that, again, the way that this evolves is these types of tests become the new CBC for the practicing hematologist. We measure disease in a serial fashion in the peripheral blood. We intervene on that progression of disease at the molecular level before they actually have a clinical relapse and are suffering from that. And if we need to, if we see something in the peripheral blood that wasn't previously there, then we can go look in the bone marrow just to validate it. So I think, I agree with you, we need to do less marrows, but we don't lose the opportunity to use the peripheral blood to help guide our therapy and decrease the number of random or simple post-treatment milestone-directed bone marrow biopsies.
I think though it's naive of any of us to say that we can do serial testing of molecular tests. I mean, the tests that you're talking about cost $4,000 or $5,000. Insurers don't pay for it often. Our reimbursement system hasn't caught up, and so that's a big issue to all these new tests. Is the tests are often 5 years behind in reimbursement, and I get more complaints now from patients not about the cost of their drugs, because we can get them their drugs, but the cost of the diagnostics that we're doing to monitor them for the drugs they're on.
Yeah, well, I can say that the clonoSEQ test, with which I have no financial affiliation whatsoever, is $950 a test. So you can do that monthly for the cost of 1 month of ibrutinib therapy. And so I would make that exchange in a heartbeat, because there are going to be many patients that you can keep off of ibrutinib for many months, if not longer, by doing serial molecular testing and seeing that they remain MRD negative. So I agree that our payment system needs to evolve to catch up with these molecular tests. There's no doubt about that. But the tests they have a bad reputation for how expensive they are. They're actually perhaps more affordable than many think. And as they scale up in bandwidth, I think that they will become even more affordable.
If I can comment, I think
Sure.
we've jumped ahead of the surrogacy question to the how we're going to manage individual patients. And I think because people feel so strongly about the value of MRD and CLL, but I think if we step back and focus on the surrogacy, I think we can have the discussion about blood versus bone marrow with a very different context, and in terms of the whole trial population versus making an individual patient decision. And I think, yes, we have a long way to go to validating and making assays available for patient decisions, but in the context of clinical trials, those who are running the trials, whether it's pharma, whether it's cooperative groups in academia, we can control and do these in a centralized, consistent manner and generate the data that is necessary. But I think it is the use of MRD that allows us to think about fixed duration treatments in CLL, particularly as we begin to think about how to combine new targeted agents that will by themselves be expensive, but we would want to have a fixed duration and provide long treatment-free intervals. And also to think about eventually getting to the point of individual patient guided therapies based on MRD results.
I just wanted to mention something about clinical trials. I had not participated in a clinical trial based on the timeline for my CLL. But given the fact that only 3 to 5% of the patient population participate in clinical trials, while they're extremely necessary, the time that it takes to collect those patients, to get them to participate, again, extends from a patient perspective of, to make sure that it's safe, to make sure that the numbers are accurate, that the data numbers are crunched properly, elongates, the time where we might be able to enjoy a quality of life with minimal residual disease that we treat more chronically than as a cure, as an endpoint. I know as the sister of a physician and a mother of a physician that, fixing it and cures are always, the laudable goal. But maybe for a nearly 67-year-old patient at this point, if I relapse, maybe that's not the best outcome. Maybe we're talking more of a younger population who can see this through over several decades. For me, I don't know. If I had MRD and I could get another 15 or 20 years out of it, that might be enough.
Great, thanks, Carol. So we do have some time for questions from the audience. So it's turn to if anybody has a comment or question to the group. A lot of seemingly controversial issues did come up with regard to the methodology, testing, and best next steps. Any thoughts from the group? Yes.
Just a quick comment.
Can you announce your name and where you're?
Lanny Kirsch, Adaptive Biotechnologies.
Great, thank you.
Just a quick comment with regard to the methodology. Aaron already has made the point that the cost is significantly less than what you quoted Dr. Bird, but also if you factor in the cost of doing a bone marrow, then overall healthcare costs, I think, are quite relevant. And also with, you pointed out that the sensitivity of sequencing is greater than that of flow. You're making a decision in the bone marrow based on flow. For the same sensitivity, you could achieve that same level of comfort, perhaps, by looking at the blood at that same time point. So it's, these things are things that are worth sort of thinking about. Again, not to say that there aren't features of flow that will, are unique and will not be done by sequencing, et cetera. But when one considers methodology, some of these other issues like sensitivity, are relevant.
So I love next generation sequencing assays, and I don't like doing bone marrow biopsies. So yeah, I think it points to where's say my favorite Wendy's commercial, where's the beef? And and part of why I didn't talk about next generation sequencing very much is there's not a lot of published. There are no phase 3 studies that have been published in a peer-reviewed journal with this yet, and so we just need to see the data. And when the data come, the data are going to be there. And until the data are here, and until the data are published and peer-reviewed, we have to wait.
There are, however, thousands of samples that have been assessed by both NextGen and either ASO-PCR and flow cytometry and shown excellent correlation. So I think that there's an abundance of reason to believe that the NextGen approach is as valid as those other methodologies.
Great. Other comments or questions to the panelists? Yes?
So this was a very interesting discussion, and I think one of the real sort of take-home points from the panel's discussion and John's initial presentation is that MRD and CLL, and also I think this goes to the other hematologic cancers, that MRD can be used as a powerful tool to design clinical trials that are aimed at providing patients best benefit from the therapeutics that we administer. We can answer important questions about timing of therapy, duration of therapy, can it be interrupted, and all of these things. And MRD does not have to rise to surrogacy status to use it as that tool.
Great. Any other Any other questions? Okay, so just to, I think we can wrap up this session and adjourn for lunch. I do want to sort of follow up on the, I think we all want to get to MRD as a surrogate. It's great prognostic, but more as a surrogate endpoint. The best steps to get there are more data are needed. I think we do want to move, and even John, to measuring it in the blood, but the data aren't there yet, and we just need to find the most efficient ways to get there. So I'd like to thank all of our panel members. We'll adjourn for lunch until 1:45. Again, just to remind you all, lunch is on your own. There are restaurants local just around the corner. You can check with our staff at the desk. And if you do want to bring it back to the room, that's okay. But we'll see you back here at 1:45. Thank you.